Good day, future doctors. So this is the continuation of our lecture on liver function test. We will now discuss urobilinogen. You have learned that this is the product of the metabolism of bilirubin 2 or bilirubin diglucuronide by intestinal bacteria. You have also learned that 10 to 20% of this urobilinogen is excreted in the feces in the form of the brown pigment urobilin or stercobilin, while 90%, 80 to 90% is reabsorbed back through the enterohepatic circulation. Majority of the reabsorbed urobilinogen are excreted by the liver, while a small portion of them is eliminated in the urine by the function of the kidney. In the laboratory, we are testing for the presence of urobilinogen in the urine and in the feces. Take note, the urine and fecal urobilinogen are increased in cases of hemolytic anemia and other diseases characterized by increased red cell destruction. Why? Because if there is increased red cell destruction, expect that there is an increase in the metabolism of hemoglobin, and that will cause increase in the levels of unconjugated bilirubin. And since there is increased unconjugated bilirubin delivered to the liver, then the liver will also produce increased amount of conjugated bilirubin. Then if this increased amount of conjugated bilirubin will be secreted into the bile duct, then into the intestine, then the bacteria will have a lot of conjugated bilirubin to be converted into urobilinogen. So what will happen? There's an increase in the amount of urobilinogen that will be reabsorbed via the enterohepatic circulation. And since the hepatocytes of the liver are already working at maximum capacity just to remove the unconjugated bilirubin from the blood, then the hepatocytes will no longer be able to secrete the reabsorbed urobilinogen into the bile duct. So what will happen? Majority of this urobilinogen will be excreted into the urine via the function of the kidney. Thus, there is an increase in urine urobilinogen. The fecal urobilinogen level will also increase because of the increase in the amount of the conjugated bilirubin that is draining into the small intestine from the bile duct. In cases of bile duct obstruction, the conjugated bilirubin is not able to reach the small intestine. Therefore, the intestinal bacteria cannot act on the conjugated bilirubin, converting it into urobilinogen. So expect that urine and fecal urobilinogen will be very low in cases of bile duct obstruction. Now the question is, how do we test urobilinogen in the laboratory? We will make urobilinogen react with the Ehrlich reagent, and it's composed of para-dimethyl aminobenzaldehyde, and it's popularly known as PDAB. The reaction of urobilinogen with PDAB will produce a red-colored compound. On the left side of the screen, you have here a test tube containing the urine sample. Added to the urine sample is the para-dimethyl aminobenzaldehyde or the Ehrlich reagent. The Ehrlich reagent will react with the urine urobilinogen, producing now a characteristic red-colored compound. The higher the amount of urine urobilinogen, the darker is the final color. Urine urobilinogen is made to react with para-dimethyl aminobenzaldehyde or the Ehrlich reagent to produce the red-colored compound. Added also into the suspension is ascorbic acid, and the main purpose of the ascorbic acid is to keep the urobilinogen in its reduced state, because once it is oxidized, it will form the urobilin, and urobilin does not react with para-dimethyl aminobenzaldehyde. So if the urine urobilinogen is oxidized to urobilin, then you will have a falsely low result. So that's why ascorbic acid is very important. Added to the urine and the Ehrlich reagent is saturated sodium acetate, and the main purpose is to simply stop the chemical reaction. In determining urine urobilinogen, a fresh 2-hour urine is collected. So the patient is instructed to collect all of his urine output for 2 hours. Now, the problem with this procedure is that there are a lot of interfering substances that can also react with para-dimethyl aminobenzaldehyde. So, listed in the PowerPoint slide on the screen are the interfering substances, and I want you to memorize them. Testing of the urine urobilinogen should be done without delay because you know very well that urobilinogen can be oxidized to urobilin. And what will happen? There would be a decrease in the level of urine urobilinogen. And one more thing, once the red colored compound is already formed, you have to read it immediately using the spectrophotometer. You have to read the absorbance immediately using the spectrophotometer. Why? The final color of the urobilinogen and aldehyde reaction decreases in intensity through time. We do not usually perform determination of fecal urobilinogen in the laboratory because we can already do visual inspection. If the stool appears to be alcoholic or clay-colored, that will already give us an idea that the patient has no urobilinogen or urobilin in his or her stool sample. But if you really want to test whether the stool sample of the patient has urobilinogen because you want to establish the diagnosis of bile duct obstruction, then you can also utilize the same chemical reaction that we used in the determination of urine urobilinogen. That's why the second bullet says same principle as that of the urine urobilinogen determination. Alkaline ferrous hydroxide is added first to the feces to reduce the urobilin to urobilinogen. You know very well that urobilinogen is excreted in the feces in the form of urobilin. So for you to measure the urobilinogen, you have to convert back the urobilin to urobilinogen. So that is now the importance or the role of the alkaline ferrous hydroxide. This is the normal histology of the liver. As you can see, you have there the septa forming the hepatic lobules. This is how the liver would appear if it is constantly exposed to injurious agents and there is what we call chronic inflammation. So what will happen? The normal tissues are now replaced by fibers. If that will happen, that is now referred to as liver cirrhosis. The problem with this scar formation is that it will replace the normal tissue of the liver. And if there is replacement of the normal tissue of the liver, expect that the liver will not be able to function the same way that it did when it was still normal or healthy. So cirrhosis is a clinical condition wherein there is scar tissue formation, and this scar tissue formation will replace the normal healthy liver tissue. And there are a lot of causes of cirrhosis. It can be fatty liver, or also known as the non-alcoholic steatohepatitis. It can be because of chronic alcoholism. It can be because of your immune system producing antibodies against your own hepatocytes, and you call that as autoimmune hepatitis. It can also be because of viral hepatitis, particularly hepatitis B, C, and D. It can also be because of genetic disorders such as hemochromatosis, which is characterized by increased deposition of iron into the hepatocytes. And with that, these iron deposits can actually kill hepatocytes. And we also have another genetic disorder, alpha-1 antitrypsin deficiency, while some can be caused by hepatotoxic drugs and toxins. The left photo is the normal gross appearance of the liver. The liver in the middle is a fatty liver. It appears yellow because of the deposition of fats in the liver tissue. And the third photo is showing us the accumulation of lipids within the stroma of the liver and cytoplasm of the hepatocytes. Left liver is normal. while the liver on the right side appears brown because of the deposition of iron, and that can cause injury to the liver, leading now to the probability of cirrhosis. Another disorder that can lead to liver cirrhosis is alpha-1 antitrypsin deficiency. So I want you to take a look at the photo on the left side of the screen. You have there a neutrophil. A neutrophil is a phagocyte. The problem with neutrophil is that every time that it is engulfing bacteria, there's a probability that some of its enzymes will leak out from its cytoplasm into the surrounding tissue. The most popular one is elastase. The problem with the leaked elastase enzyme is that it can cause tissue destruction. That's why you have there in the photo a protein that will neutralize the elastase enzyme, and that is alpha-1 antitrypsin. So I want you now to refer to the photo on the right side of the screen. In the absence of alpha-1 antitrypsin, the elastase enzyme is free to cause tissue destruction. So, people who are born with deficiency of alpha-1 antitrypsin will most likely have organ damages brought about by the elastase enzyme. And the two most commonly affected organs in alpha-1 antitrypsin are the lungs and the liver. So just try to imagine, every time that there's the presence of microorganisms in the liver, the neutrophils will migrate there and they will be destroying the liver because of the leakage of elastase enzyme. And that can cause scar formation in the liver, and that can lead to cirrhosis. The next disease that we will be talking about is Reye's syndrome, and this occurs in children. One of the things that can help the doctor arrive with a diagnosis is that these patients had an history of viral infection. On top of that, these patients were given aspirin. So if the patient developed viral diseases such as chickenpox, flu, and gastroenteritis, and if that patient is given aspirin, there's a chance that the patient will develop the Reye's syndrome. The reason or mechanism behind how the aspirin and the viral causative agents can cause the Reye's syndrome is still not clear up to this point. What the scientists only have are datas that can tell us that the cases of Reye's syndrome are more common in children who developed chickenpox, flu, and gastroenteritis, and they were given aspirin by their parents or guardians. Take note, this Reye's syndrome can lead to non-inflammatory encephalopathy. Why? Because the liver cells are already dying. They cannot anymore detoxify ammonia to urea. And ammonia is a known neurotoxic chemical. So these children will really have encephalopathy. And it is also accompanied with degeneration of liver cells. So if you have a patient who just recently had a viral infection, and then the patient was brought to the clinic or the hospital, and then you found out that there is a problem in the liver, and the patient has manifestations pertaining to CNS involvement, then that should raise the suspicion that the child could be having Reye's syndrome. Now let's talk about the cancers of the liver. The cancers of the liver can be classified as primary or metastatic. When you say primary, the cancer began in the liver. But when you say metastatic, the cancer started in another organ. It's just that it was able to spread and involve the liver in the process. Now, metastatic cancers are more common than primary liver cancer. 90 to 95% of the cancers involving the liver are most of the time metastatic. And they are actually from colon cancer, lung cancer, and breast cancer. The tumors or cancers of the liver can also be classified as benign or malignant. Benign tumors of the liver include the hepatocellular adenoma and hemangioma. And the most popular malignant tumor of the liver is the hepatocellular carcinoma or hepatoma. The first benign tumor of the liver is the hepatocellular adenoma. This is characterized by the presence of a single or solitary mass found within the normal appearing liver. And this mass doesn't cause significant damage to the liver tissue. That's why it's considered as benign. Majority of the cases of hepatocellular adenoma are found in young women who are using estrogen-containing medications. Most of the time, these women are asymptomatic. If they will develop pain and other associated symptoms, that's the time that these women could be subjected to surgical removal of the mass. The next type of benign liver tumor is hemangioma, and this is characterized by the presence of clusters of blood-filled cavities. So I want you to take a look at the mass on the liver in the picture. Can you appreciate that it's dark red in color because you have there a lot of red blood cells, because that mass is basically composed of cavities that are filled up with blood. Most of the time, this mass does not cause any symptoms, and surgical removal is rarely needed. This is the picture of the biopsy of the hemangioma. As you can see, you have here cavities that are filled up with red blood cells. The malignant tumor of the liver is called the hepatocellular carcinoma. This is caused by liver cell damage. And if the liver cell damage becomes chronic, then you expect that the liver will develop cirrhosis. And if not treated immediately, then that cirrhosis will eventually lead or progress to hepatocellular carcinoma. Listed here are some of the causes of hepatocellular carcinoma: hepatitis B, C, and D, because these viral hepatitis are known to cause chronic hepatitis. With their chronicity, they can really cause cirrhosis, and eventually the cirrhosis will lead to the occurrence of hepatocellular carcinoma. I will explain later on aflatoxin of Aspergillus flavus. Then you have hemochromatosis, the deposition of iron into the liver stroma and parenchyma. Then you have alcohol. Aspergillus flavus is a fungus that we can find commonly in peanuts and corns. And this fungus can actually produce an aflatoxin. And aflatoxin is a potent carcinogen, and it can cause the development of hepatocellular carcinoma. That's why it's very important for us to check the corn and the peanut that we will eat. Make sure that they do not contain the Aspergillus flavus, the green-colored cottony colonies that you can find on the corn and peanuts on the photos. At this point, we will be talking about the liver enzymes and how can we utilize them in the laboratory to diagnose cases of liver disorders. But first, let's have this slide. So I want you to take a look at the hepatocyte. Beside it is the sinusoid, where you can find the blood. And then I want you to take a look at the yellow-colored figures. Those are the hepatic enzymes. These enzymes should be found intracellularly or within the cytoplasm of hepatocytes, although there are small amounts of these enzymes present in the blood. The thing is, if the hepatocytes are exposed to injurious agents, then these cells will undergo lysis. The enzymes in their cytoplasm will start leaking into the blood. And the presence of high amounts of this enzyme in the blood would signify cell damage. So, we need to know what enzymes are found intracellularly in our hepatocytes so that if they are present in high amounts in the blood, that would tell us that there is an ongoing cell damages among hepatocytes. The first liver enzyme that we will discuss is aspartate aminotransferase. So from the name of the enzyme, it's supposed to transfer an amino group from aspartate. So let's check the chemical reaction catalyzed by this enzyme. You have here the substrates aspartate and alpha-ketoglutarate. As you can see, the amino group, which is the one highlighted in red color, of aspartate will be transferred to alpha-ketoglutarate. Alpha-ketoglutarate will become glutamate, and aspartate will become oxaloacetate. The other name for aspartate aminotransferase is serum glutamic oxaloacetic aminotransferase. And for you to easily remember that, look at the products of the chemical reaction. You have glutamate and oxaloacetate. And take note, AST, aspartate aminotransferase, is also known as SGOT. And for you to easily memorize that, pag may asked, merong sagot. Sagot. Asked, AST, sagot, SGOT. So if the hepatocytes will undergo cell lysis because of exposure to injurious agents, the AST enzymes in their cytoplasm will start leaking into the blood. So high levels of AST enzyme in the blood can suggest the probability of a liver disorder. But the problem with AST is that it is widely distributed. It can also be found in the heart and skeletal muscle. So that's why if your patient has hepatitis and acute myocardial infarction at the same time, you will never know if the high AST level in the blood is because of the hepatitis or is it because of the acute myocardial infarction. Plus the fact that AST is found in higher concentration in the heart than in the liver. That's why, as you can see, I intentionally replace letter O in SGOT with the heart shape. That is to somehow make it easy for you to memorize that SGOT is found in higher concentration in the heart than in the liver. So, we need to look for an enzyme that should be found almost exclusively in the hepatocytes. And what enzyme could that be? That is the alanine aminotransferase. So from the name of the enzyme, it will transfer the amino group of alanine to another substrate. So what substrate is that? The alpha ketoglutarate. So you have here in the reaction alanine and alpha ketoglutarate, and the amino group of alanine will be transferred to alpha ketoglutarate, and this alpha ketoglutarate will become glutamate, and alanine will become pyruvate. The other name for alanine aminotransferase is serum glutamic pyruvic aminotransferase. And for you to easily remember this, look at the products of the chemical reaction. You have glutamate and pyruvate. Alanine aminotransferase is mainly found in the liver. That is in contrary to AST. So therefore, ALT is more specific to liver than AST. So if you have a patient who is probably having a hepatitis, you should request ALT and not AST. Expect to find high levels of these aminotransferases in the blood in cases of viral hepatitis because there is destruction of the hepatocytes by the viral causative agents. Then you have drug or toxin-induced hepatitis and hepatic ischemia. Especially if, let's say, for example, the surgeon accidentally cut the hepatic artery during the surgery. Then, increased in ALT is greater than that of AST in liver disorders because ALT is more specific to the liver than AST. Take note of the third bullet. We will discuss this further later on. ALT or an AST may be mildly elevated in bile duct obstruction. So, the clinical application of ALT and AST is more on hepatitis and less of bile duct obstruction. So we need to look for an enzyme that will help us diagnose a case of bile duct obstruction. The enzyme that can help us diagnose cases of bile duct obstruction is alkaline phosphatase. In the liver, this alkaline phosphatase is particularly found on the cells that we can find lining the bile ducts. That's why if there's a problem in the bile duct, then expect that these cells will produce and release increased amounts of ALP. I will read the third bullet. More elevated in cases of biliary obstruction than hepatitis, and that's in reverse with ALT because in ALT, it's more increased in hepatitis than in bile duct obstruction. The problem with alkaline phosphatase is that, similar to AST, it is widely distributed. It can be found in the liver, particularly in the bile duct, bone, particularly the osteoblast, intestine, kidney, and placenta. And for you to easily remember that, HOPIC, hepatic, liver, O, osteoblast of the bone, P, placenta, I, intestine, and K, kidney. So if there is a problem with any of these organs, or if the woman is pregnant, expect that that person or that pregnant woman will have increased ALP in his or her blood samples. So why do you think alkaline phosphatase is elevated in pregnant women? Because they have the placenta, and placenta can produce alkaline phosphatase. Why do you think it is elevated in children? Because children are actively growing. Their bones are extending, and for their bones to extend, the osteoblasts will deposit bone matrix, and osteoblasts produce high amounts of alkaline phosphatase. Why do you think alkaline phosphatase is elevated in bone disease? Because if the bone is destroyed, the bone will try to repair itself by activating the osteoblast, and osteoblasts will produce high amounts of alkaline phosphatase. So the problem with alkaline phosphatase is that, yes, it can be used to diagnose bile duct obstruction, but it can also be elevated in other conditions. That's why we have this next enzyme, 5-nucleotidase. The level of this enzyme becomes significantly high in hepatobiliary disease. So that's why if the ALP is elevated and you're not sure if the elevation in the ALP is because of the liver or maybe because of the bone, placenta, intestine, and kidney, you should back up your result with 5-nucleotidase, because this one is exclusively found in the bile duct. So that's why in the second bullet, you diagnose the case as bile duct obstruction if there is elevation of both ALP and 5-nucleotidase. But if it is only the ALP that is elevated and 5-nucleotidase is not, then you should start entertaining other possible sources of the high alkaline phosphatase. If 5-nucleotidase is not available, then you can have the gamma-glutamyl transferase or GGT. Aside from being useful in the diagnosis of bile duct obstruction, GGT is a microsomal enzyme. And when you say microsomal enzymes, these are enzymes in the liver that can be produced in high amounts if the hepatocytes are exposed to a particular chemical. In the case of GGT, it is produced in high amounts in the presence of alcohol. So if the person has been chronically drinking alcohol, expect that the GGT enzyme will be produced in high amounts by the hepatocytes. That's why this enzyme can also be used to assess cases of chronic alcoholism. And that ends my lecture on the liver function test. Also included in the coverage of the quiz is our Zoom class discussion on viral hepatitis. So if you have questions with regards to my discussion of the liver function test and viral hepatitis, please don't hesitate to ask me on my social media accounts. Thank you very much.